those of you who follow neurotraumatology will know that the CRASH 3 trial was recently published, and Pakistan had a significant role in this, and it is that role that I wish to focus on, because it's been an excellent experience, suggesting that we really are well placed to do such trials. So just the prelude to all this is that traumatic brain injury is a major public health problem, particularly in newly motorizing countries, and the incidence is expected to rise. We, as we all know, the thrust of our management is to restore the best possible milieu for the brain to recover. We certainly don't have any pharmacological intervention to assist this process. And this trial was designed to look for evidence about the effect of tranexamic acid in the mortality and disability of patients with TBI. And it also wanted to look very carefully at the risk of vascular occlusive events and seizures. So this trial was an international randomized double-blind placebo-controlled trial across 6 continents, 29 countries, 200 hospitals, and over 3,000 collaborators. And it was originally planned to recruit 13,000 patients. The eligibility was adults with traumatic brain injury within 3 hours of injury, and either with any intracranial bleeding on the initial CT scan, or in its absence, a GCS of less than 12. Exclusion was patients who had significant extracranial bleeding. So when the trial closed recently, at the end of January this year, 12,737 patients had been randomized, of which 4,567 were from Pakistan. That's 36% of the total. And it's that aspect of the trial that I wish to focus on in this presentation. The follow-ups and completeness of data was excellent. We had 99% follow-up across the board. And the number of sites in Pakistan of the 175 was 14. So a smaller number of sites, but large contribution in terms of number of patients. So the total number of Pakistan patients was 4,567, and the next largest group recruited was from the United Kingdom, where most of the major trauma centers participated, followed by Malaysia. And these 3-4 countries really formed the bulk of the patients recruited to the trial. The trial recruitment actually started back in 2013. Pakistan, as you see the blue bars at the bottom, came in about 15 and rapidly escalated its recruitment numbers. And I was fortunate to be involved in trying to mobilize that, and am extremely grateful for the support received from colleagues across Pakistan, but particularly from Lahore General Hospital and from Services Hospital. Tariq Salahuddin has just walked out of the room. A great salutation to him, because he was one of the early embracers of this. Professor Anwar is here. He was very much part, and Professor Khalid Mahmood was a great facilitator, and the trial, and I personally am extremely grateful to them. So this gives you a sense of that. Here are all the units listed, and this is their contributions. So the Lahore General Hospital, Unit 1, Unit 2, and Unit 3 are separately displayed here. And along with Jinnah Hospital in Karachi and Jinnah Hospital in Lahore were the bulk of the recruits. These are our premier public health institutions, And quite honestly, this trial, in a sense, is a tribute to their work in trauma management. So in Pakistan, in the urban areas in particular, the ambulance networks are well placed, and these major hospitals have facilities for quick transfer. So if you look at the time to randomization, the blue bars are Pakistan, and Pakistan was skewed towards the earlier transfers to hospital and early randomization. So we were pretty good in that. In other words, because of the fact that our major hospitals are placed in an environment where there's good ambulance services, time to randomization can actually be pretty good. And as you saw in the earlier graph, when we look at how the 3-hour window was to be approached, we were doing quite well in that. In terms of the level of consciousness or the severity of injury at the time of randomization, we would skew a little bit towards the more severe patients, and that I think reflected in the results as well. So even though there's a lot of sort of minor head injuries that come to hospitals, the numbers that were recruited in Pakistan compared to the global red bar averages was less. The severity is perhaps reflected, I'm not sure that this is true, but perhaps reflected in the fact that the mean blood pressure was lower in the Pakistan recruits. And one big difference was that the number of patients who were recruited without a CT scan, based on their level of injury and the level of consciousness, was something that was more than the global average. So if you look at the no CTs, and what you see is that close to 50% were recruited without a scan. But in the people who did have scans, and what we found out later, after randomization, the Pakistan patients who are recruits who are more skewed towards epidural hematomas and parenchymal hematomas. And again, perhaps a reflection of the fact that we had slightly more severe patients. Very often, unlike other places, the attendants' relatives will be at hand when the patient is approached by the medical team or the neurosurgical team to get consent to entry to the trial. And so we had a large number of consent obtained, and we very rarely had to go to a waiver of consent process, which was well defined in the protocol of the trial. So we come now to the heart of it, which is the event rate, and the event in this was death within 28 days. And for Pakistan, it was 22%, which is kind of, if you look at it compared to global averages, was just slightly more. Other countries were 16%, and we were 21%, 22%. And if you look across the countries, there's quite a variation, which is not easily ascribed to state of health system. And in fact, another analysis, which I'm not showing you here, which looked at outcomes according to low, middle income strategies, stratifications by the finance organizations, showed that in fact, overall, the mortality was slightly less in the low, middle income countries. In terms of complications, it was interesting to me that we had our complication profile was slightly on the diminished side, particularly in terms of sepsis. And whether this is a reflection of the hospital environment, the health systems, and so on and so forth, is not very clear to me. But I think that it is borne out in this particular slide, where you look at the cause of death, which is overwhelmingly, of course, is head injury. But if you look at things like pulmonary embolism and multi-organ failure, then those are not seen as much in the Pakistan patients. And either one can argue that this is perhaps insensitivity of diagnostic capability, or you can argue that we don't have the kind of sepsis issues that pervade other hospitals and ICUs. But that's not clear, and that would need to be looked at. Neurosurgical operation. So everywhere hematomas were evacuated, but the number of non-hematoma procedures was less in Pakistan, and that kind of is explained by the fact that the other procedures were largely insertion of intracranial monitoring devices, which is not as current in Pakistani neurosurgical practice as it is elsewhere. This trial was a tremendous logistic exercise, as you can imagine, because the drug was, for all 12,000 patients, 13,000 patients, was the placebo in the drug was sourced from one place and then distributed. And getting a drug into a country requires a lot of work with the regulators and the customs authorities and transport. And so one of the great strengths of this trial, which was revealed to us, was the strength of having the advantage of having a good coordinating center, with a couple of full-time employees devoted to following up with the regulator, following up with the sites doing the recruitment, so that the drug is in place in time, and so on and so forth. And my own experience and the other colleagues will bear out that we did fairly well against in difficult circumstances. And if you look at the delays in drug distribution, we were kind of not very much off what was happening in some of the other countries. The other good thing was that if you looked at what was missing from the baseline data, most centers were very good, and Pakistan was very good as well. There's one issue that relates to the missing in 65 of the patients, where the GCS was not either clearly entered or missing, and that had to be looked at, because we always did source data verification. So the other thing that we learned was that if you want to maintain good quality of data, you have to have people going and looking randomly and regularly at all the sites, checking against what they've been doing to verify that. And I'm very pleased that compared to the global average, all the data was verified in a good number of the patients in the Pakistan group, and the number of corrections required was actually lower than the global average. So it's an experience that showed us that if the neurosurgical units and their heads and their faculty work together, we're really well placed to do this kind of multi-center work and advance the cause of neurotraumatology and other issues in neurosurgery. And finally, I just want to share with you the main results slide from the trial, which I showed yesterday at the meeting as well. And what it shows was that tranexamic acid is useful, and it does reduce deaths, particularly with two caveats. And the first caveat is that the patient must be in a situation where the head injury has not devastated his brain, so it's got to be mild or moderate head injury. And secondly, you've got to give it early before this kind of secondary hemorrhages accumulate in contusion blossoming and contusion expansions in the brain, because it can't correct the primary damage, and it certainly can't alter in any way the hemorrhage that's already happened. So with that, I want to once again thank all the colleagues particularly in the centers in Lahore and Rawalpindi and Karachi. And congratulations to Team Pakistan. Thank you.